Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. We welcome Dr. Nasser Al-Amry, consultant chest radiologist from King Fahd Medical City. Welcome, Dr. Nasser.
Ahlan wa sahlan. Thank you very much for inviting
So
me.
I would like to discuss one patient with you. My patient, she is a 25-year-old female who presented with sudden onset chest pain and shortness of breath. So we requested for her CT pulmonary angiogram. Can you elaborate and enlighten us about the CTBA?
Yeah, absolutely. So this patient got multiple filling defect, which extended from the main pulmonary artery, and you can see here that the filling defect is extended to the lobar
Can you use the
segmental.
pointer? Yes.
So lobar and extend to also to the segmental and subsegmental branches, and it gives you some good radiological sign of the donut sign. So we can see here the central filling defect with the peripheral contrast going through. So that means that this vessel is trying to save himself from this filling defect and try to perfume or perfuse the lung.
Very interesting. Very interesting.
Yeah, so and this is actually involving the both lungs. So here we can see it in the right side, and here is the left side. So this is the left main, and the lobar branch going down to the segmental, and here is the subsegmental branches. And again, the problem about acute pulmonary embolism is the effect to the heart and the cardiac strain. So here we can see that the pulmonary artery is slightly dilated, we measure it as 30.
What's the normal size?
It's 28 average, but actually there are multiple articles talking about distribution regarding age and sex, but people use 28 as a cut point. But the thing is the discrepancy in the right ventricle to the left ventricle chamber. If it's getting higher or larger right ventricle, we use 1-to-1 cut point. But here we can see that the enlargement of the right ventricle with the reflex of contrast to the hepatic vein, that gives us a radiological evidence of cardiac strain or right side heart failure. Again, something interesting in this case is the presence of a wedge-shaped peripheral consolidation. So that actually is a part of pulmonary infarction related to the pulmonary embolism. So it's this case actually got all the pulmonary embolism, cardiac strain, and pulmonary infarction. So it's really a classic. If you see here the pulmonary infarction, we can see the central lucency representing some areas of early cavitation, and the wedge-shaped peripheral is actually a classic sign of pulmonary
So this
infarction.
is the way to differentiate it from consolidation?
Absolutely, yeah. So the problem about radiology is the controversy and overlap between infection and infarction, but the presence of filling defect, the wedge-shaped peripheral consolidation with central areas of lucencies represent more of infarct. So this is how we
I think the
differentiate.
other important question, can we call it massive pulmonary embolism from radiology standpoint?
Yeah. So as a massive pulmonary embolism is yes, because all the loops, the main pulmonary arteries, segmental, subsegmental, have been affected. So there is no preserved lung. We usually tend to use massive pulmonary artery or massive pulmonary embolism in a case that got all the loops affected with the secondary pulmonary cardiac strain, pulmonary infarct. So that will fit to this case.
Excellent. But the clinical diagnosis from our standpoint, massive pulmonary embolism, if there is hemodynamic compromise,
Yeah.
i.e. Hypotension.
Absolutely. So that's from a clinical point of view, but from a radiological point of us, as you know, we don't know what's getting with the patient. We try to elaborate the sign with the term that, but definite this patient is having the definite massive pulmonary embolism all the loops and segmental subsegmentals have been affected. There is a secondary effect of the cardiac strain, pulmonary impact. So nothing left to keep it away from non-massive.
I think this has emphasized the importance of discussion between radiologist and clinician. If you have any imaging modality, I think each complement the other, and always I say that radiologist seeing the patient or looking at the patient through a whole, and clinician seeing the patient as a whole.
Totally agree. Totally agree. And actually, if it's fit to the clinical, more likely it fit to the radiological, and things as working as multi teams will be at the end to the patient benefits actually.
Excellent. What are the contraindication for CT angiogram?
Well, as for the risk versus benefit, we try to use BE and give it more in a favor rather than eliminated or restricted from being done. The most and the thing that people we are afraid of, if there is an absolute contraindication to contrast. If the patient has an absolute contraindication to a contrast, will actually worse him by giving him a contrast, then we're gonna save him from being in a pulmonary embolism. The other thing is the relative, which is the pregnancies and the low probability in the clinical side. Renal impairments, will people try to get renal impairment as a very high in some centers, but some people find that renal impairment or renal is high creatinine is something that they can save from the point of view. But the absolute contraindication is the high risk or absolute allergy from contrast.
Allergic contrast. Anyway, so what's the best imaging modality for pregnant patient? There is a controversy. Is it a CT angiogram or a VQ scan? So would like to enlighten us about this.
Absolutely, yeah. So in a pregnancy, the most likely, if you would like to start with the lower limb Doppler, and if it's positive, that will give you a hint and no need for PE or VQ. If it's negative, then there is a question about using CTPE or a VQ scan. Most of centers have been utilized VQ scans instead of pulmonary CT, but with the revolution of the CT scanners, and we are actually getting much lower radiation with the new generation CTs scanners. So the new the new technique give you very low radiation. So PE, CTPE in a pregnant lady start to be a relative, not an absolute contraindication.
Excellent. So can you just quantify what's the radiation exposure to a pregnant patient from the chest X-ray, the CTBA, and the new technology of CTBA?
Yeah, if you utilize, if you start to radiate or utilize the optimal low dose strategy in a CTPE, you will actually getting about 0.8 millisieverts, and even if you can reduce it to 0.5.
Which is equivalent how many chest X-rays?
Well, it's so let's compare it to a regular PE. So the regular PE will ended up by
regular
13.
CTBA.
Yeah, so regular CTBE angiogram is about 13 millisievert, but in if you reduce it to 0.5, you actually getting from almost 10 or more times reduce in the dose, with preserved quality of imaging to be reported. So the VQ scan is about 8 millisievert. CT is, if you use it for regular patients, it will be from 10 to 13, sometimes jump to 30 if the patient is a huge, large patient. So that will actually be changed, and people are trying to use CT with optimum radiation dose rather than VQ
Scan.
in compare. Yeah.
Excellent. What's the take-home message, Dr. Nasser? Okay.
It's actually CT pulmonary angiogram is a gold standard in a case of suspected pulmonary embolism. If you have it and you suspect it clinically, CT should solve the problem.
Excellent. And we should always urge all trainees to discuss radiology finding with the radiologist if you have any doubt.
Absolutely. If you have somebody who have been more expert in dealing with the chest or pulmonary thromboembolic pulmonary disease, well, solving acute from subacute and chronic will actually benefit the patient. Well, discussion open a new strategies.
Excellent. Dr. Nasser Al-Amry, consultant chest radiologist from King Fahd Medical City. Thank you very much.
You're welcome. Thanks.
Okay.